Welcome to another episode of Winning Healthcare Food Fights. I hope you join me, Hunter Schultz, each week as we bring more clarity and understanding to health and wellness without the mess. We have something a bit different for the next two episodes. My guest has an inspirational story of a young man on a mission who learned some valuable life lessons along the way to becoming a physician. He is the living embodiment of a quote attributed to Confucius: "Man who say it cannot be done should not interrupt man doing it." After his story, we'll begin exploring health savings accounts, better known as HSAs, which are currently like Roberto Duran fighting Sugar Ray Leonard with one hand. They're capable of so much more, but they're limited. So for these next two episodes, we'll dive deeper into what HSAs are, their history, and more about the undercurrents preventing them from fulfilling their promise. My guest has served at numerous teaching medical centers throughout his career. He was a consultant nephrologist in Kalamazoo, Michigan, and the medical director for the Free Clinic in Kalamazoo from 2007 until it closed in 2010. He graduated from Tufts University with a major in chemical engineering and with distinction from George Washington University School of Medicine. He is the author of 3 books: In Defiance of Death, Exposing the Real Costs of End-of-Life Care, a free ebook, The 10 Questions Walter Cronkite Would Have Asked About Healthcare Reform, and Understanding Healthcare, a Historical Perspective. Dr. Kenneth Fisher, welcome to the show.
Thank you, Hunter. It's a pleasure to be on the show.
For those wondering, what is a nephrologist?
A nephrologist does an internal medicine residency first, and then studies the diseases of the kidney and how to treat it, and then gets into dialysis and artificial ways to keep people alive who have failed kidney function.
So you woke up one morning and decided to become a doctor.
Yes.
And I'll take a fashion risk on there being a story behind it. So why a physician and then you went to kidneys?
Right. Well, it's kind of an interesting story. I grew up thinking I'd be a chemical engineer and go into the chemical business. So I was attending Tufts University in Medford, Mass, in the chemical engineering program, and was on my way. Then in the summer between my junior and senior year in college, I developed appendicitis. So I went to our physician and told him my complaints, and he did a number of physical exam tests, and a few laboratory tests in his office. Told me, that I had mild appendicitis, and probably the thing to do was to just wait and see what happened, which I did, and went to see him the next day, and it cleared up. And so as he was explaining the process to me, I became fascinated with it. Wow, this is sort of, a biochemical engine that we are. And it fascinated me much more than chemical engineering. So I changed courses. But I finished chemical engineering in my senior year. And while I was taking finals in chemical engineering to get my degree, I attended summer school at another university nearby, Boston University, because they do 2 semesters each summer. And of course, I hadn't taken biology. So I took biology courses during finals.
Wow.
In chemical engineering. And just before I graduated, the head of the department called me into the office, and he said, you haven't had any interviews for jobs. And jobs were very plentiful, and they still are in chemical engineering. And I said, no, I've decided to try to become a doctor. And he looked at my record. Now, chemical engineering grades are a lot different than pre-med grades.
Hmm.
And he said, I don't think I just don't think you have a chance. And I remember saying to him, well, we'll see. And it turns out he was wrong. Of course, I had to get all A's in these courses I took in biology at BU to raise my cumulative average. And at the same time, I was watching Mr. Nixon's draft list because once I graduated, I lost my education deferment. So, so I enlisted in the Army in a reserve unit that was part of the Massachusetts General Hospital Reserve Unit, which hadn't been called up in Korea, only in World War I and World War II. So I figured, okay, that's pretty good.
Playing the odds.
So I, I was, and at the same time I was applying medical schools. So I ended up in basic training, this, that, and the other thing, and and while I was in basic training, I got a call from my mother, which of course they don't accept. But she said, "Oh no, he's just been accepted in medical school, to the operators." So she put the call through. So, so I'm there in basic training, and the sergeant comes by and says, "Come on to the office." And there was my mother on the phone. So
Wow.
I had an interview at George Washington University School of Medicine. So I somehow finagled during basic training to get a pass for the weekend to go to a medical school interview. And lo and behold, I got the interview, flew in, flew out, and about 3 days later was accepted. There, so so that my plan was to get out of to exit my basic training course for as a 6-month reservist and start medical school. However, nature has its way, and I developed insulin requiring diabetes while I was there. So
Wow.
of course they said goodbye. We don't want a soldier with diabetes.
Yeah.
And I started medical school. So at our medical school, as in most medical schools, there are alumni in the area who will provide care for people. So I figured, while I had insulin requiring diabetes, I should probably go to a specialist in diabetes. So I went to this fellow. I still remember his name, but I'm not going to say it. And he said, no insulin requiring diabetic has ever graduated from medical school. You're going to have to quit. And that was the last time I saw him. And I said, no way. And I was very fortunate, did very well. Oh, by the way, my father died while I was a junior in high school, so we had no money whatsoever. So I was very fortunate. I did quite well and got an alumni scholarship, and they paid my tuition throughout medical school. And while in medical school, I wanted to join a journal club. So we can talk. I wanted to talk about, new ideas of how to deal with disease and this, that, and the other thing. And the best journal club was the Nephrology Journal Club. And that fascinated me because it's kind of a joining of engineering, chemical engineering, and human biology. So fate had it that I was kind of predestined to do this. So therefore, I became a nephrologist.
It sounds like you're the living embodiment of something my dad loved. He was a keynote speaker, and he loved to use this one phrase or one line attributed to Confucius. And you're the living embodiment of man who say it cannot be done should not interrupt man doing it.
Exactly.
And I think, and it was something else that he used to tell me is he said, son, everything is related. The big problem is seeing the relationships. So
Right.
when you mentioned chemical engineering and then the kidneys,
Right.
I started thinking, wow, if there's ever a chemical engineering going on.
Right. Exactly. It just fit. And then also, being a physician and nephrologist, we see a lot of end-stage kidney disease from diabetes. Um, so I've been an insulin-requiring diabetic now for 55 years. Most people with insulin-requiring diabetes that long are long gone, but it helped me greatly taking care of myself. So,
Sure.
as far as I know, I'm still here.
Were there any cultural influences motivating you in terms of continuing on with medicine and
Probably. Um, when I was 12, I had to start studying for my bar mitzvah, being Jewish.
Mhm.
So, of course, I wanted to go out and play, but my mother had other ideas.
as they
So,
usually do?
yeah, so I was I had this. I, I was going to a Hebrew school, and I had a teacher specially for bar mitzvah, and so I sort of didn't study that hard. And so, about a month before it's scheduled, or a couple of weeks before it's scheduled, I the teacher called my mother and said, you better cancel this bar mitzvah because your son is not ready." So I got home from playing, of course,
Ooh.
and my mother sat me down and said, "You're going to learn this now." And after about 15, 20 minutes of her threatening me, I learned it.
The memo got through, yeah.
Right, right. And so I remember going the next day to the tutor, and I went through the parts, and they're in Hebrew and in English. You have a Hebrew speech, and you read the Torah, and et cetera, et cetera. There are no vowels. It's quite difficult. And then you have an English speech, and this, that, and the other thing. And I went through it like crazy. Zoom. And he said, "It's a miracle." So,
Alert the Catholic Church.
right, it's a miracle. But it taught me something. And it was the first time I really actually used studied hard. And lo and
Hmm.
behold, if you study hard and you have some ability, you can do it.
Hmm.
So,
Yeah.
and that's probably a very important lesson, that whatever you aspire to, if you work hard at it, you can do it if you have some basic talent. And if
Yeah.
your aspirations are within reason.
Yes.
uh,
Walking to the moon just
yeah,
isn't going to
it's not going
work.
to happen, right? But,
No.
but it gives you a sense that, well, you do have some intellectual capability. You can you can accomplish things. Of course, it's hard work. You got to really concentrate, but you can do it.
Yeah.
So I would say that probably was a critical experience, to be able to pursue a dream of being a physician, and to have the confidence to leave chemical engineering, go to summer school, then take some more courses in the fall and spring to build up my grades, to have the confidence to even attempt it. And of course, if you don't have that confidence to attempt it, you'll never do it.
Hmm.
So,
My sister says I have the gift of gab, and I thought, you know what? I think what I'm going to do is start a podcast. And because I'm in the midst of finishing up the book. The book is the same title as the show, "Winning Healthcare Food Fights Without the Mess."
right,
And having conversations about healthcare down here teaches you a lot because there's so many people from all over the world, and you learn a lot. And so, uh, it's hard work. I mean, a lot of people don't realize the professionals make it look easy. And there's a reason for that. It's preparation,
Right.
preparation, preparation,
Exactly.
training, etc. And I'm learning a lot while doing this. And living as a segue, living here in Panama means that I have a pretty broad view of U.S. healthcare. I'm not bombarded by the minutia that a
Right.
lot of Americans
Exactly.
are. And though I'm from Chicago, I've been here for over 15 years, but our systems are different. It's more direct here and less governmental involvement.
Right.
And so I've I've heard of health savings accounts. So what are they? And then
Sure.
we'll go on from there.
Well, a fellow by the name of John Goodman, uh, and another fellow whose name slips my mind right now, asked a question. Since World War II, healthcare was provided as a benefit to try to draw people out of the home to work in the factories during the war. And because of wage controls, they could only give benefits to appeal to people. And one of the benefits became health care. And they first gave the employee a healthcare policy in the company's name, and the company made the assumption that it was pre-tax dollars. And in the Eisenhower administration, it was codified that yes, when you get health insurance from an employer, it's pre-tax. So and that has grown and grown for multiple reasons. And then we can talk about how what we call health insurance is not really insurance. It's prepaid health care with a
Mm-hmm.
tremendous bureaucracy in between, in between the patient and the person supplying the health care, being it the physician or the hospital. And so these fellows, John Goodman, asked a question. If the company can give the employer in the company's name pre-tax health care, why can't the company use the same pre-tax dollars and put it in the individual's name in an account that is only for healthcare? And he's a PhD economist. And he thought, well, this would be a good idea. Then people would be in charge of their own healthcare, um, and 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 therefore that would work. So of course it took him years to get it through, Congress, and in I believe in 2003, George George Bush signed the beginning of health savings accounts. And it first had slow growth, but now it's about 25 million Americans have health savings accounts with about 65 to 70 billion dollars of assets. But there's a competing thought, and this is critical. If you're an insurance company, your margins are pretty low. So their profits about 2, 3, 4%. So the way to build more profit is you need a much bigger gross. The way to have a bigger gross is to be in charge of everything. So every time you see a doctor, they say, okay, well, we'll pay for it. Every time you get expensive a medicine, we'll pay for it. So that tremendously increases their gross. So it's really not insurance. Insurance is something that, like your automobile insurance, your car gets wrecked, they pay. So it's a catastrophic event. But car insurance doesn't pay for gasoline, doesn't pay for tires, doesn't pay for upkeep. So they changed the idea of health insurance to actually be prepaid health care. So it is in their interest to say to the American public, we will manage your care. We will take care of you. They even spread the word that, oh, if you're in charge of your own money in a health savings account, you may not want to use that money for healthcare because you want it to accumulate over years, which is one of the advantages of health savings accounts versus health reimbursement accounts. So they spread this word that you are really incapable of managing your own care. We'll do it for you at great cost. And so you have this tug of war that it's in an industry's interest to convince the American public that the individual is unable to direct their own care, which of course is an absurdity.
Sure.
Of course you can direct your own care, but you can only direct your own care if you're in charge of the money.
Yeah.
And 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 just to reinforce this, the number of physicians in the United States is growing. So we don't know if there's a physician shortage or not because of the way it's structured. But there are more physicians now per 1,000 Americans than ever before. However, when you have this corporate care, the number of non-healthcare personnel has grown by over 3,000%. Of the about 3.2, $3.5 trillion in healthcare, 1 trillion goes to pay for all the intermediary people who are just watching the money.
And generating processes in the same time.
And of course, profit.
Yeah.
So you got to ask yourself, and it's sort of an accident of history because of World War II, and also the concept of healthcare not driven by the individual, but driven by the government. That started in Germany by Otto von Bismarck, then transferred to Great Britain by Lord George when he was Chancellor of the Exchequer about 1906, I believe, which then became the precursor of the National Health Service. So when these things began, Otto von Bismarck, Lord George, they didn't have a way to put the money into the person's name. Of course, they could have given some kind of credit or some kind of chit of some kind, but they didn't. So they built the facilities from which you would get your health care. And that started this idea that it has to be a centralized, government-dominated idea if it's going to work, which of course is not correct. There are all kinds of alternatives, but throughout history for the last over 100 years, it's been assumed that the only way you can bring healthcare to disadvantaged people and everybody else, in fact, in many countries, is for the government to own the facilities, and it's totally outside the market economy. And
it's a lot of inertia.
You now see how we got into this unbelievably complicated, expensive, and sad system.
Mm-hmm. So what would be the overall, well, let me back up a moment.
Go ahead.
They fit right now within the current system. They're limited, as I compare it to Roberto Duran fighting
Right.
Sugar Ray Leonard with
Yes.
one hand. What are the limitations right now?
Well, when they first started, you could pay for over-the-counter drugs and this, that, and the other thing. There were, but the Affordable Care Act, otherwise known as Obamacare, said no, you can't do that because, again, that idea was centralized. So there's this intellectual battle going on that, again, can the individual direct their own care, or do you need a third party, be it the government or the insurance company, to actually run the system, and the individual fits in as care is needed, but it's not directed by the individual. So number one, when they started, since it's a tax exclusion, there's a limit each year to the amount that you can put into a health savings account. And about every 5-7 years, they raise that limit a little bit, but it is not, it could be much greater. To me, there should be no limit to the amount of money you put in this account. And also, you want to understand, to have a health savings account, you also have to have a catastrophic insurance policy, or what they call high deductible insurance policy. And we'll talk about one of the ways to really allow people of any means to be able to have a health savings account is the deposit each year should equal the deductible, so that if you spend more than you put into it each year, if you get ill, then you've already paid your deductible, then the insurance, takes over. But high deductible insurance plans are much less costly than regular health insurance.
Right. I have that.
Right. So the problem is because you need congressional action, because it's under the tax code, then you have this battle between the insurance companies who want to have prepaid health care, because again, that tremendously increases their gross, which increases their net, versus the individual who can direct their own care. So my question to you is, who do you think has more lobbying money? The insurance companies or the individuals who would like to direct their own care?
Yeah. Oh, that's an easy one.
Right.
Insurance companies. Yeah. Something else, when you mentioned congressional action, I immediately thought, well, there's a brilliant oxymoron if there ever was one.
That's right. Yes.
So the overall impact on care when using them right now is limited. There are benefits.
Right.
But let's just say that I know you're on board with direct primary care, as am I.
Right.
And so let's just go with direct primary care as the standard of excellence for humanity.
But I would add direct. I would take the word primary out and say direct care. I would like
direct care.
To see a day whenever you saw a doctor, be it a family physician, general internist who is taking care of your overall health. And I believe it's critically important to have a person like that, a physician who you really trust, whose only function is to look out for your benefit, not working for an insurance company or a government agency or anybody else, but only works for you. That means you pay them cash out of your health savings account. And so any physician visit, any physician takes care of you in the hospital or ambulatory should be, in my opinion, paid cash from your health savings account.
Yeah.
So that means there is then a market determination of your value. And right now, nobody knows what that is.
Right.
Because it's all third party, and actually it's driven by the Medicare payment schedule, which we can talk about, which is all arbitrary.
Yeah, throw the dart at the board.
And nobody knows what actual value is. But to me, so you have to have transparent prices. So physicians would, post their prices on be it in internet or in the office or any way. And then people negotiate, just like, you want to buy a car. People are going to probably spend as much money on cars, on automobiles in their lifetime as on healthcare. So, you go to the dealer and you say, oh, I don't know. This seems a little expensive to me, et cetera, right?
Right.
And you buy a car. So why can't you do the same thing for healthcare? So when you see a physician, but again, it's in the insurance company's interest to say, no, you can't do that. You're just a single person. We will negotiate for you. Right.
Mm-hmm.
And then
Where's that? Where's the incentive to lower costs?
actually the incentive is to increase because
Right.
that would be a bigger piece of the pie for them. So the incentives are all wrong.
And I agree. I know on my Twitter feed, I know you're on Twitter, and you see doctors like Dr. Chris Held, who's an ophthalmologist.
It's a lovely lady. She really has nerve too, let me tell you. I know her
Gumption.
very well.
And she talks about how she saves her patients money and time and
Oh, it's unbelievable.
yeah, and in terms of how much their wallet is impacted, it's truly remarkable. She's one of the warriors out there that you
Right.
just have to.
Right. And then another pace setter is a fellow by name of Keith Smith, who, with a surgeon partner, he's an anesthesiologist, started the Surgery Center of Oklahoma. And they were the first one. They have a website that has a human figure on it. And for every procedure on that mannequin is a price. And their prices, when they started, were about an order of magnitude less than the hospital across the street. So,
They haven't gone up, have they?
no, they haven't gone up for 15 years. So he and this partner of his, they were working in this hospital across the street. And they were saying, how come we can't get the latest equipment? Oh, well, the cost is so great. And da, da, da. So they said, oh, this is ridiculous. So they hawked everything they had and built and bought a building, refurbished it as a surgery center, got other surgeons to join in, and they started this idea of market pricing. And they didn't know if they were going to succeed, and it has been wildly successful. They get people from all over the world come in. Of course, the internet, the growth of the internet
Right.
really helped them. They get people from all over the world, and many, many people from Canada, who have to wait, 3 years to get a hip replacement or something like that. And they pay him a very reasonable amount,
Hmm.
and they get it, within days.
But quickly, yeah.
Right, and people from all over the United States are flying into Oklahoma City to get, and of course, it's had an effect. It's had an effect on the prices that hospitals have to charge in Oklahoma City, and many of those hospitals now are just about copying his prices, which shows that it can be done. But there's a
Right.
complicating factor here, Hunter, that people don't realize. It's very important for them to know. Medicare, with their price fixed fees, underpays cost by about 10%. Medicaid underpays cost by about 50%. So, how do hospitals keep the doors open?
Hmm.
By negotiating with private insurance companies for excessive prices. To give you an example of the loss, I think it's in my book. In 2008, the Mayo Clinic, I forget the exact numbers, did about $1.7 billion of Medicare, of which they lost around 800 million.
Oof.
So how do these places keep their doors open? By charging private insurance much more than cost. So what does that mean? That means that employers paying a healthcare benefit, uh, paying an increasing price all the time, which means the employee gets less salary, which means the employee is actually subsidizing Medicare and Medicaid, which
Hmm.
means the next generation is subsidizing Medicare when the whole reason that they passed Medicare was to help the middle generation, the working people who were paying for their children's education and for their parents' care, to relieve them of some of that responsibility. That was the main argument for the creation of Medicare in the first place. Yet, there's now this huge hidden tax that people don't realize that they're paying to subsidize Medicare and grossly subsidizing Medicaid.
On top of what's already coming out of their paychecks.
Exactly. So, of course, what's coming out of their paychecks is the Medicare tax. So, and they're paying and they're putting that money in, which they believe is going to pay for their medical care when they're retired. But of course, it's not true. They're only putting in about 1/3 of what their medical care is going to cost. So therefore, taxes, the general tax fund has to increase tremendously to keep up with this cost. And
there's no incentive to lower costs.
None whatsoever. And of course, the individual retired person, those over 65, retired or not retired, they have no idea of what they're spending. They feel, including myself, well, I've put into this account, I deserve to be able to use it.
Sure.
But of course, there's no idea of a real price. The hospitals are playing all kinds of games. The whole system is so convoluted. And this is one of my major concerns about Medicare. When Roosevelt started Social Security in 1935, the average age was 65. So half the people died before they could collect. So the government was doing great. However, when Medicare and Medicaid, when Medicare was signed in 1965, Johnson knew there was a baby boom. And so that the number of people receiving these funds would increase relative to the number of people working, paying into the fund, because it's a pay-as-you-go fund. But of course, he knew it couldn't work. But he figured, what the heck, let people 40, 50 years figure it out.
Wow. Well, here we are.
And then there are two other factors. One, life expectancy since 1965 has gone up considerably. And the third factor, so the working population down relative to the people spending the money. 2, life expectancy has gone up. And 3, the medical armamentarium has greatly increased. And now there are treatments that in 1965 nobody even thought could exist. And these are great advances. And they should, and of course they should be encouraged. So that the only way Medicare can actually function realistically is if the money is put in the individual's name and not spent by the government the day it's collected, and grows over time. Because the medical expense is always going to grow over time. So that money, in my opinion, and some others, should be put into a special account, so the payroll deduction that everybody pays should not go to the federal government, but should be put into the individual's account that would grow over time, and to make it real safe, half stock market, half bonds. So in case somebody retires during a dip, they can use the bonds. So and so you'd have to phase that in over many decades to fund the present system, and it's the only way it can survive without this greatly increasing cost. And then, of course, if it's in your account that you then merge with your health savings account when you're 65, you have to know the prices of everything you buy. And I believe you should pay 1% of your hospital costs also. So it's not much. So you're in the hospital for a very serious issue, it costs $100,000. You're paying $1,000 from your health savings account. But that means you know what the prices are.
Yeah, you have skin in the game.
Exactly. And that would be catastrophic insurance.
Yeah. What types of care can and should HSAs be allowed to pay for? I mean, DPC comes to mind, but also specialists and
Oh, I think that health savings accounts should be used to pay for all care, and that you have a catastrophic insurance policy on top of that. I mean, things happen, right? You can have a heart
sure.
attack, you can get an automobile accident and be in the hospital for 2 months with 16 broken bones. I mean, so you have to have, but you would go and purchase this catastrophic insurance policy across state lines, so that then all the different states and their various insurance regulators on jacking up the costs, and that would be paid for out of your health savings account. So you
Hmm.
would purchase your health care, both daily and regular care, pay for cash, and your catastrophic insurance policy as a consumer. And every individual would direct their own care. And I propose to do this as a voluntary thing. In other words, give American people the choice. You can either,
Hmm.
which I think would make it much more saleable to the public. You can either be in charge of your own money, or many people, especially let's say Medicare recipients who are in their 80s and 90s, would say, no, that's okay. I'll pass this time.
Hmm.
So make it, instead of us forcing people into a system, let people choose.
Choice.
Do I want to direct my own care? Or do I want some insurance company to run it? Or do I want the federal government to direct my care? If I do, okay, that's fine. That's your business. I believe most Americans would say, wait a second. I buy a house, I buy food, uh, I buy cars. I'll buy this too. And then there's
Hmm.
another issue with food, and that is Congress says, oh, if you can't afford anything, food, we'll give you food stamps, same as cash, right?
Yep.
And you take it to the market and you buy food. So you are directing your own care, your own food supply.
Hmm.
So why can't you do that with healthcare? I mean, food is more important to stay alive than healthcare, right?
Yeah, it's not an healthcare is as needed, whereas food is a necessity along with shelter
Right,
and water.
exactly. So if Congress says, oh, okay, you can be in charge of getting your own food, here's the money if you can't afford it, why can't we do that with healthcare?
That goes to healthcare being the healthcare is a right. It goes to healthcare being so-called a so-called right versus,
Well, yeah,
and I don't believe it is, but
right, but you're still supplying the right to be able to get it.
yeah, I think I think that's part of something that HSAs give a lot more flexibility, and I think it will help with portability of care. If you change jobs, you're not married to your former employer's insurance and your new former or your new
Exactly.
employer.
Right.
That's a big deal.
No, it's a huge deal. And now think of this for a moment. Look whose advantage it would be in if people chose the HSA route, if you're employed, the HSA route.
Hmm.
Right now, a family of four, most employers are paying about $20,000 to $22,000 a year for a family of four's health insurance. That's $22,000 pre-tax. That really is salary not being paid to that individual. So let's just say that individual decided to go the HSA route. That would cost about, between having cash to take care of the family and buying a catastrophic policy, would cost about $10,000. Wait a second now. That means if the employer, Ford Motor Company, gave the employee $10,000, $12,000, into their health savings account, take care of the family. The employee now could get the $10,000 more in salary. That would be taxed. So the federal government would benefit, the individual would benefit. The loser is the third-party insurance company.
With huge lobbying.
So who is paying a fortune to maintain a system that is costing the employee another $10,000 a year in salary. And by the way, this increase in healthcare premiums to subsidize Medicare and Medicaid and the inefficiency in the system because of the bureaucracy is the major reason why salaries have not kept up with cost of living. And the government would also recoup tax money.
You'd probably they'd gain more in taxes because you're unleashing.
That's right.
You're unleashing the private market.
And you're giving the employee about $10,000 more in salary.
There's a marketing, yeah.
Right. So the individual is losing, the company is losing, the government is losing, but the third-party healthcare industry is gaining.
So the next election is coming up, and I think in your book, Understanding Healthcare, an historical perspective, you take people on a guided tour of healthcare's journey to where we are today, and you've done that a little bit today on the show. And something I noted in there was the personalization of medicine as a key theme, and people may not be on the same page hearing the same thing. So what do you mean by personalization?
Well, this goes into one of the reasons I left chemical engineering and became a physician. When you're, and you know this very well, when you're in the business world, you have to carry yourself in a certain way. And you sort of put on the face, what the Japanese call the face. You have to be cordial. You have to be careful what you say when you're contracting with another business. You have to have a certain way about you. You're going to be very careful. You don't talk about personal things too much. Yet, when I thought about this, I wanted a relationship where people would be totally free to talk about their innermost fears, their innermost concerns, the mistakes they've made throughout their life, and we all make our share.
Yes.
And somebody that you can really be honest with. There's no reserve. Somebody you really trust to keep that confidence. Somebody who can advise you, saying that somebody you really trust, you're drinking too much alcohol. It is not good for you. It's time to cut down. You've gained 35, 40 pounds in the past 2 years. This is not good. This is going to lead to trouble. You've got to, and let's talk about what you're eating. And perhaps you maybe should cut down on fried food and have French fries and potato chips. You have these fantasies. Everybody has them. Don't dwell on it. But of course, you got to understand that, you have to be careful the way you carry yourself. Well, you can't have that relationship when the physician has their nose in a computer all the time, that with present rules, everything that physician writes down, puts down in one of these computer programs, which, by the way, have to be certified by the federal government, so that it totally limits creativity and entrepreneurship in the programs that doctors can use. Doctors cannot choose a program that helps them communicate with patients better. They can only use a program certified by the federal government that actually inhibits their communication with patients. And then that is on the internet. As a matter of fact, you might have read recently that Ascension, one of the largest healthcare operations in the country with something like 2,000 hospitals, has a deal going with Google to send the patient's name, social security number, and everything else, and all their health data to Google. And Google is going to then find the secret of health. There's no hypothesis. They're just going to generate the data, look at the data. And of course, it's absurd. There'll be no benefits from this whatsoever. The scientific method, which I talk about in my book, is the key to progress that man has made the last 500 years.
Sure.
The federal government has decided that no, we're not going to do hypothesis-generated research in healthcare. What we're going to do is go on a giant fishing expedition and just pick things out, which is absurd. It'll never work. So it's going against 500 years of learning how to do research. And so there's no privacy. The whole thing is ridiculous. And the only way you can escape it right now is for the physician to go cash. That's the only way.
That's the privacy, something that I spent, oh gosh, I spent a few months writing that one section because the research I was doing just scared me half to death.
It's terrible what's going on. And it's all this, politicians are using computers to specify a susceptible voter who will, who they can turn their way. So why can't we do the same thing in healthcare?
Mm-hmm.
Well, they're all politicians.
Well, they
making these decisions.
Yeah, as I've said on a number of the shows now, that when I look at Medicare for all, I'm not surprised. I mean, when you look at what government is all about, it's for all.
Right.
It's in the Constitution. It's in the Bill of Rights. And when a politician sits down, they're thinking, well, I have to do this for all. And I can't. And when they get into trouble is when they start to personalize stuff. And then they get caught and ooh. But the big problem is what's in those records, especially primary care. That's where the mother lode is. But it's something that I'm really concerned about, and that is with physicians, that your entire reason for being and the enabler for that is what you just said. It's that relationship you have with the patient, that they trust you, that Hippocrates 2,400 years ago said, what your patient says to you stays with you.
Exactly.
And, in software, it's garbage in, garbage out.
Unbelievable.
And when I think of personalization of care, medicine itself is moving in a completely different direction from for all. And since you've been around long enough, it used to be for you, I would think probably early on, it was more someone walks in the door and you've got the male-female diagnostic charts. Now you have genome, gut microbiome, you mentioned a lot more tests,
right,
in general. So now that's part of that, what I consider personalization of care. The drivers for this in the last 20 years, it hasn't even been 20 years since the first mapping of the human genome.
Right.
But now it's within a couple of years, it'll be down to $100. So with a primary care doc, wow, that's an enormous tool that hasn't gotten into the primary care space until recently. And it's going to get further into it as the price drops from, we're now under $1,000 to we're going to $100, maybe $200.
Right.
But from your standpoint, goodness. So dialing it in on nephrology, I mean, how do you think, or what have you heard about your specialty changing over the last 10 to 20 years because of things like genome and other diagnostic tests?
Well, that's a very good question. It's difficult for me to say that this massive increase in information has been boiled down to points where it's beneficial to a patient. I don't think we've reached that stage yet. Most of what we're doing is pretty much what we've been doing for the last 15 years. There is some work. It's sort of diagnostic capabilities have greatly increased. For instance, you can now submit renal biopsy material and get a much more specific idea of what's actually going on than you could, let's say, 15 years ago. That has improved tremendously. So you can understand better the effects of this particular pathologic process on this individual. But has that led to better therapy? Somewhat, but I don't think we've reached the stage yet where we're able to say, well, you're that the gene profile controlling this process, we can change that a little bit and fix the process. We haven't reached that yet.
Yeah.
I think it's coming. I think it's very important when you talk about tests is to rigorously understand the limits of the tests that are out there.
Sure.
And again, as we've corporatized, I'm not sure I'm saying it right, as we've done this corporate medicine, we're unable to spend the time with each patient that's necessary. And so what happens is you order a whole battery of things, hoping you'll come up with something. So the paradox is the more you corporatize medicine, the less time you spend with that the physician has with the individual, the more tests the physician has to order, the more expensive it becomes. So that's one of the reasons why the past 20 years, instead of medicine benefiting from understanding these tests better, when to use them, when not to use them, et cetera, hasn't led to decreased costs, led to increased costs.
Yeah. Is part of that from the decline of primary care?
Yes.
You don't have that resource.
Yeah, there's no captain of the ship.
Yeah.
Right. And of course nobody's in charge, but the individual isn't paying anybody to actually be in charge.
And they don't realize that it's possible to have that.
That's right.
Well, theoretically. I mean, well, I won't say theoretically. Let's just say it's growing. It's a growing movement with direct primary care, direct specialist care, but especially direct primary care.
Right.
And I have one question that,
please,
since I'm a student of history, I've always loved history. And aside from the obvious and learning the history of medicine from your book, the perspective it brings, how else does it help, or would it help today's patient and ultimately next year voter?
To understand better understand the situation we're in, and that we can. I think there's a draw that is that some of my colleagues do not understand, and that is almost all Americans believe that every American should have access to healthcare. And that's the moral, ethical draw that politicians are using to get to be in more and more control of healthcare. But of course, that doesn't have to be, right? We
Right.
we can do what Mitch Daniels and Seema Verma, who is now the head of CMS, did in Indiana a decade ago, and that is, if you can't afford your health care, we'll put a deposit in an account in your name, and we'll buy you a catastrophic insurance policy, and you will direct your own care. These were Medicaid patients, and of course, their care costs went down 30-40%, and their health care improved dramatically.
Sure.
Emergency room visits went way down because they can now pay cash like everybody else.
On top of that, don't you think it's the fact that when you're spending your own money, a lot of Medicaid patients are, they want to get back to work, they just can't. And it's because the system is preventing them from getting the care that they need to get over whatever it is they've got. Not all, obviously, but many of them would love to get back to work. And I know that's an issue.
I think you've said a key point, which I have always believed. Why should I pay taxes so that somebody else who is unable for any reason to earn enough money to get their own health care, why should I pay taxes to give it to that person? And the answer to me is very simple. Why, being a grandfather and my wife a grandmother, should we pay taxes to our community to fund schools? I don't have children in these schools, but it's to my advantage to fund that school, because I want these children to learn as much as possible so that they can become productive citizens. That then increases the GDP of the country, that then increases the wealth of the nation, that then increases my standard of living. So I say it's the same thing for healthcare. I want everybody to be as healthy as possible so they can be contributing to the national economy. It's in my interest so that they're contributing to the national economy. GDP goes up, everybody's wealth increases, including mine.
Yeah.
So I'm not saying be altruistic. If you want to be altruistic and feel good about it, that's your business. But it's really in everyone's personal interest that everybody be as productive as possible. Then there's another issue. The CDC has determined that health, a person's healthcare determines 20% of the population's health. Socioeconomic status contributes 60-70% of somebody's health. We're spending these huge amounts of resources on health care at the cost of funding the education of our children, who will not have the ability to escape the status of poor, the generations of poor.
Mm-hmm.
So it's self-defeating, isn't it?
Sure.
When Medicaid first started, there were 2 million people enrolled. Now there are 22 million. So we're funding this healthcare component, which is a small fraction of the population's health.
Right.
And every state in the country now spends more on Medicaid than it does on education.
Yeah. And if you do the math, I've said this on a few shows already now. If you do the math, $77 a month is the average direct primary care monthly membership
Right.
fee. And, if you take it out to 329 million Americans, it's a little over $300 billion gets people care, real good care.
Right.
So you're talking 22 million people on Medicaid. You're probably talking somewhere around $20 billion a year to give them great health care, which in turn can help them become more productive members of society and
So
get back on their
true.
feet.
And you know what Medicaid is costing now?
Hmm.
Over 500 billion.
Yeah, the numbers are astounding. Now, granted, direct primary care isn't going to it will handle a whole lot, and in fact, a whole lot of chronic care patients can then drop down from specialty care and that cycle. They go to a specialist, and then they wind up in the hospital, and then they go to the specialist, and there's no quarterback for their care. There's no one paying attention to the details. But with direct primary care, you can drop a lot of those people, not all, but many of them down, so that direct primary care practitioners can take care of chronic care patients more effectively. And there's a huge cost savings there. So
No
that
question.
300, that 20 billion, it's probably less than $20 billion that you would spend on Medicaid patients for their primary care, which everyone needs. And you're going to spend some money beyond that. Maybe it's another 100 billion for hospitals, accidents, or whatever the specialty care they might need. But you're dramatically improving their care, and you're dramatically improving the odds of them moving back into society. So, as we wind up the show,
Yes, sir.
what do you think are the key HSA takeaways? Maybe one or two in particular.
I would say that HSAs are a way that people can direct their own care. They can take the health care that they're getting and put it into their own hands instead of having third parties telling them what to do. And it will allow them to have a much better relationship with the people taking care of them, physicians, hospitals, nurses, etc., and will relieve the people who are giving this care, doctors, nurses, who are spending more than half their time on computers and various administrative tasks than actually devoted to the care of the patient. So the individual can get far superior care and have a sense of a relationship with people, doctors, nurses, that is much more satisfying than this impersonal, corporatized, government-controlled care that we're now selling to the American public.
Right. Well, we're going to have more information on the show's website and with links to your books, and
Great.
and we're going to put some snacks in keeping with winning healthcare food fights.
There you
We're going to
go.
put some snacks to share on our YouTube channel, so the listeners can go on over to winhff.com. That's win, WINHFF.com. And there are more resources there too. Dr. Kenneth Fisher, you really helped us, certainly me, understand health savings accounts and their impact on care and wallets. And thank you for being on the show.
Well, Hunter, it was a pleasure. And if there are questions that come up that you would like us to repeat, and answer, or if there are other issues you'd like to raise, I'd be very happy to help.
Well, thank you. And I have a feeling we'll be revisiting with you down the road as we get closer, not only to the election, but as things progress. And
it'd be great.
Thank you again. And also a big thank you to my listeners. And until next time, there you are. Thanks for listening to the Winning Healthcare Food Fight Show. Hit the subscribe button to hear more expert thinking on getting better care without the mess.